Thank you very much for your kind invitation to speak about electrophysiological support in the current diagnosis of MS. Because the new diagnostic criteria have added the optic nerve, I will focus my presentation on visual evoked potentials and complement them with optical coherence tomography. These are my disclosures, not related with this talk. And I would like to say that all the data coming from our laboratory have been collected and discussed under the guidance of Professor Giancarlo Comi. And we will discuss not only about the diagnosis, but also about the differential diagnosis. In fact, if we can consider the recent consensus paper on the diagnostic criteria of optic neuritis, there were also instrumental criteria, paraclinical criteria, and I have to say that we included only OCT and MRI, and I have to say I could not manage to include the VEPs with my colleagues, mostly because the experience with VEPs is not so widespread, especially in the US. But now that the diagnostic criteria also consider the possibility to use VEPs, I hope the expertise on this technique will increase. In our lab, we do actually all the techniques, not only VEPs, we also do multifocal VEPs, OCT, together with clinical assessment of vision. And but concerning VEPs, I think it's more useful for this talk to concentrate on the standard VEPs that are more widespread in different labs across the world, and that allow to stimulate full field one eye at the time separately, and to record a single waveform to obtain latency values and amplitudes. But I have to say, amplitudes are not so clear to interpret because they could be affected by many conditions, while latency is quite relevant because relevant latency delay is suggestive of a demyelinating condition. And also OCT is now very widespread across ophthalmology departments, but also neurology departments. It's a quite easy examination, especially for patients. Of course, it requires expertise, but it allows to measure with the micron resolution the thickness of the neuroaxonal layers in the retina. And in most devices, we can have not only a global value, which is here in these maps in the center of the map, but also sectors. And this could be relevant in the differential diagnosis because in the MS condition, normally the temporal sector is mostly affected. And considering visual evoked potentials, we have to take into account also the heterogeneity across labs, also in not only in the device, but in how we use the device. And this could be relevant in the sensitivity to demyelination because the smaller check sizes are going to test the most central part of the fovea and then the most central portion of the optic nerve, which is most frequently affected in multiple sclerosis. So, like in this example, you could have normal or almost normal VEPs to large check sizes and to see a delay, a very relevant delay, only with small checks. And also, if we perform a VEP and we don't see any trace, this is just a sign of abnormal optic nerve and not of demyelinating conditions. So this could be relevant for the differential diagnosis. and it could be important to consider repeating the exam to see the delay. We repeat the exam after steroid treatment because conduction block in MS can most of the times resolve and allow to measure a delay in VEP. In multiple sclerosis or in any optic neuritis, there is a paradox dissociation between the retinal nerve fiber layer thickness, which is normal or can even be increased in case of edema in the acute phases, and requires about 3-6 months to be evident. And for the ganglion cell layer, 4 weeks are enough to see a reduction, while the VEP latency is mostly abnormal in the acute phases and it tends to recover slowly over time. So this can also affect the sensitivity of the exam if we wait months before we perform the testing. And in this cohort of our patients, 21 acute optic neuritis, we can see that already at 1 month after the onset of symptoms, there is already a great recovery in the latency, which is depicted in the graph, and waiting 6 to 9 months is going to reduce the sensitivity of the exam. And this is better clarified if we consider the frequency of abnormalities in the same optic nerves as in the previous slide, where about 30% of exams of OCTs are abnormal and 90% are abnormal in the acute stage, while if you wait 1 month or 3 months or more, then the sensitivity of the two techniques is going to be very close. And this could explain the discrepancies between different papers concerning the sensitivity of VEPs that is ranging from 96 to like 63%. But in the cohort with the 63% sensitivity, the exam was performed within 1 year. So I suppose that this is the main reason for the lower sensitivity in cohorts studied, also allowing later times before performing VEPs. And similarly, in this fundamental paper by Angela Vidal-Jordana from SEMCAT, it was demonstrated that the VEPs can add to the diagnosis of optic neuritis and in turn to the diagnosis of MS. And in this cohort, the average time to the exam was around 3 months. So again, this could explain the relatively good sensitivity in this cohort. And in a work a few years ago, we compared the sensitivity of VEP and OCT in chronic optic neuritis, and with similar results. But in subclinical optic neuritis, we found higher sensitivity of VEP. But I have to say that in this work, we did not consider the inter-eye difference, which could increase the sensitivity of OCT as demonstrated more recently. For example, in this paper, multi-center paper, where we also participated, combining patients with and without optic neuritis, the consideration of inter-eye asymmetries increase the sensitivity and specificity of the detection of optic neuritis. And of course, we could also consider to increase the specificity by increasing these cutoff values. And again, if we consider inter-eye differences, as in this second paper by Angela Vidal-Jordana, again, the sensitivity of the two techniques is not so different. So VP and OCT, if we consider inter-eye asymmetries. And we have to say that even when we are able to make a diagnosis of MS using the other topographies and not optic nerve, testing the optic nerve could be important because even subclinical abnormalities are associated with a greater disease burden early in the disease, so it could have a prognostic value. So not only for the diagnosis, but also studying this topography anyway could be useful. And also it could be useful in the differential diagnosis. So even though it's a straightforward optic neuritis without the need of paraclinical measures, this could help in identifying the type of optic neuritis, because not only the optic neuritis could be due to a pure demyelinating disease, and please consider that MOGAD is demyelinating, but is not MS, but also neuromyelitis optica was called a demyelinating disease, but actually it's not, it's an astrocytopathy that is also damaging both myelin and axons. And the axon damage is leading to an important amplitude reduction or absence of devo potential, but not a great delay. And this could be relevant in the differential diagnosis if you see a patient with severe visual impairment, but not such a severe delay in VP. This could be a red flag for NMOSD. And also considering OCT, another red flag is a widespread reduction in the thickness of the retinal nerve fiber layer, which is more typical of NMOSD compared with MS, where the temporal portion of the papillomacular bundle is mostly affected, because that is reflecting the most severe reduction in axons in the central part of the optic nerve. And we also compared OCT and VP in a cohort of people with NMOSD and a cohort of people with MS. And we found that not only it is quite rare to have a VP delay in NMOSD in the absence of optic neuritis, but it is also quite rare to have retinal nerve fiber layer thickness higher than 60 microns. And also it's quite rare to have a delay of more than 150 milliseconds, while this can also happen in asymptomatic optic nerve involvement in people with MS. And so this is also explaining why we can have a different correlation between VP delay and reduction in retinal nerve fiber layer in people with MS with a very good correlation, while in NMOSD the correlation is not so good, because we can face a very severe reduction in retinal nerve fiber layer thickness, but not such a corresponding increase in VP latency. While in MS, big reduction, severe reduction in retinal nerve fiber layer thickness is almost always associated with a residual important delay in VP latency. And so we also could show this concept by combining the severity of abnormality expressed in Z-scores with the sum of OCT Z-score and VP Z-score, considering retinal nerve fiber layer for OCT. And we could separate MS with more imbalance towards VP delay, separated from NMOSD with a higher imbalance towards retinal nerve fiber layer thickness reduction. And in MOGAD, we have something in between, because we have a severe VP delay, but we also have a very severe retinal nerve fiber layer thickness, which has a pattern more similar to that of NMOSD, in the sense that it's not only severe, but widespread, not selecting selectively affecting the central part of the optic nerve, as in MS. Actually, we know also from imaging that the most external part of the optic nerve is affected in MOGAD. And so this can explain why there is no selective involvement of the central portion of the optic nerve, and therefore not a selective temporal sector reduction in retinal nerve fiber layer. Another peculiarity of MOGAD that can be seen in the acute phases is a typical swelling of the retinal nerve fiber layer in the retina. And again, this is to show how widespread can the reduction in retinal nerve fiber layer be also in MOGAD. And of course, it was explained by a frequent involvement of the same optic nerve several times in subsequent episodes. But like in this work, this eye, the right eye, has a severe involvement, but there were 3 optic neuritis episodes. But in other works, selecting only patients with one single optic neuritis, again, there is still a severe reduction in the retinal nerve fiber layer thickness, which is also more widespread compared with MS, where it's more focused on the temporal portion for the reason we said. And so I would like to show one example of a patient that we saw with very severe visual impairment on the left eye. But when we performed the VEPs, there was actually no delay, although when we performed the OCT had severe swelling. So it was very strange because severe swelling in MOGAD is accompanied by a VEP delay. So this was not typical of MS because there could be swelling also in some cases of MS, but there is also, especially if there is a visual impairment, which is obvious in the case of such a severe swelling, it is accompanied by severe VP delay. So this is a very atypical for both MOGAD, no VP delay, and for MS, no VP delay. Both diseases could have swelling. Swelling is not so typical of NMOSD, so also it's a strange case also for NMOSD because we shouldn't see such a severe swelling, although in cases of blurred vision with involvement of axons, we should also see a reduction in VP amplitude, which is also not the case here. So it was a very strange case. By looking at the VEPs, I have to say I thought she was simulating visual impairment because the VEPs were quite symmetrical. But when we see the OCT, it's impossible to fake this swelling. So actually, we kept investigating, and we found that she had neurosyphilis with HIV, and both conditions can affect the retina. So this was not optic neuritis and not demyelinating disease. So to conclude, we can say that the optic nerve is now an achievement for the early diagnosis of MS, and that paraclinical tests can help even after during the first days after the onset of symptoms, but they can also help in detecting subclinical optic nerve involvement, especially if we consider inter-eye asymmetries. And so, but even if we make a diagnosis without considering optic nerve, I would recommend to perform both tests, also in the view not only of a prognosis, but also to detect the future relapses and future subclinical relapses. So this could be important also for the future monitoring of our patients. Thank you very much for your attention.